Good evening, ladies and gentlemen. Welcome to the Singapore Cancer Society Prostate Cancer Awareness Webinar. Thank you for tuning in on Zoom as well as Facebook. My name is Ivy Lim. I am the volunteer with the Singapore Cancer Society. In the past, we have always held our public awareness program in auditoriums where we do live speakers and also Q&A. Today we have changed due to COVID, and in order not to deprive everyone from the knowledge and know more about prostate cancer, this is a webinar and we are now inside a studio. We have observed all the social distancing, and on Zoom, if you join us on Zoom, you would see that there's a Q&A button. In the Q&A button, I would like to see if anyone could press 1 if you actually have joined other programs before. Our other awareness program before, so we know we have friends from afar or people that we know. Thank you very much, and it's good to see all of you again. And we would also like to invite you at home to help us spread the awareness of prostate cancer and sharing the FB stream and starting a watch party on Facebook. You can also subscribe to our social account on Facebook, Instagram, YouTube to stay up to date and connect with us even after this event. Now, how do you start a watch party on Facebook? You can do this by creating a post and click on the watch party icon. It looks like a movie popcorn. And search for the prostate cancer webinar and post it. If you have any questions that you would like to answer, remember to type your questions in the Q&A section, and do note that we will try to answer as many questions as possible at the end of the sessions. For those of you who are watching us on Facebook, you can also press like so we know you've joined us, and very warm welcome to you. Today we have 3 speakers in the studio, and may I now first introduce the gentleman on my left, Mr. Clarence Heng. Mr. Clarence Heng is also a Singapore Cancer Society Walnut Warrior and a patient ambassador, and he's also a cancer survivor of prostate cancer. And on my right, we have Dr. Lincoln Tan, who is a consultant urologist from Tan Urology. And on my further right is Dr. Terence Lim, Chief and Senior Consultant, Department of Urology of the Changi General Hospital. Dr. Lincoln Tan and Dr. Terence Lim are both part of the Singapore Cancer Society Prostate Cancer Awareness Committee and also Singapore Cancer Society Prostate Cancer Survivorship Program Advisory Panelist. Are you all ready to hear more about this little organ that is almost the size of a walnut, and what does it do to a man? I'd like to invite Mr. Clarence Heng to share with us your journey. I understand that you have actually contracted prostate cancer, and could you please introduce yourself and let us know how did you find out you have prostate cancer, and what are the symptoms you have experienced before the diagnosis? And, did you go through any treatment? What kind of treatment? And any side effects or complications throughout it? Clarence.
Thank you, Ivy. I am now 65 years old. I'm also a retiree. Now, during my career days, my company usually send me for health screening regularly. And inside this health screening, there are multiple items. One of the items is termed as PSA. It's called Prostate Specific Antigen. It's basically a cancer tool marker that checks whether your prostate has cancer or not. Now, throughout all the years, I have 0 for this particular item. However, in 2013, the number jumped to 3. Perhaps 3, you cannot confront the doctor, neither would the doctor do anything, because the specification for a normal person with PSA is below 4, 0 to 4. So somehow I'm anticipating whether subsequent years it will come. Then in 2013, the number jumps from 0 to 3. Now, sorry, and again, I cannot do anything. So in 2015 October, from 3, it jumped 3-folds to 10.5.
Oh.
So in a way, I get a bit worried. So I was referred to Singapore General Hospital, Urologist Associate Professor Henry Ho. So Dr. Ho did another PSA for me, plus 2 advanced items like MRI, magnetic resonance imaging, also biopsy with 12 points of sampling. And really, the result revealed in the biopsy, I have a second stage of cancer cell. So perhaps as a patient, when you receive this news, you'll be in shock first. Yeah. However, after shock, you have to calm down, stay focused, and face it.
Yes.
So my doctor told me there are 2 ways. In fact, he referred me to a cancer center, the oncologist, for a second opinion too. So both doctors have discussed and they put in front of me whether I do a surgery, which is termed as Da Vinci micro robotic surgery, which is as shown on the picture here, or I do a radiation. After that, I decided I better go for the surgery once and for all. So the surgery took about 3 to 4 hours, and I took a rest in Singapore General Hospital for 2 nights and 3 days. Perhaps some patient may take only 1 night, 2 days. It all depends on individual. And after I was discharged, I was somehow feeling that kind of side effect with me. It is called incontinence in urination. So it is very severe in the first week, or rather the first month. I almost changed 4 diapers a day. And subsequently, within the 6 months, gradually it drops down. And after 6 months, it's basically quite well. And after 9 months, I in fact take out a tour to Shangri-La, which is at 4,000 feet sea level above, and walk through the so-called the scenic area for almost 6 hours, 4 or 5 kilometers.
9 months
without
after
anything.
your surgery. 9 months after your surgery.
Yeah, 9 months after my surgery, as can see in this picture here. So without any problem, you no need oxygen tank either, 4,000 meter sea level. So it was kind of feeling Dr. Henry Ho did a good job for me. I'm appreciating his help. So subsequently, I must say that this cancer, it is not as severe as many other types of cancer, which is very high impact and instant, causing you maybe leading to your death. But this is gradual, and in fact, a lot of times there is no symptom at all. So within my past few years of this PSA, even hitting 10.5, I have no symptom, completely no symptom. So I was happy with the surgery outcome, and I find that I should contribute back to the society. So in that manner, I joined Singapore Cancer Society with the Walnut Warrior Support Group. At the same time, I registered myself for a proper training to be a patient ambassador. And throughout my past 5 years of cancer journey, I have helped 9 patients walk through the journey. Some are stage 1, stage 2, some are stage 3. So I wish to mention to the patient that you do not walk the journey alone. Because in this cancer journey, you have 3 groups of people that can help you. One perhaps is the doctor. You have to get advice from doctor, have confidence in him, believe in him, follow his advice. Number 2 would be your spouse, because in the first 1 month, it is very tough. She may have to bathe for you, she has to cook nice things for you to eat, to help you back to your normal stage of nutrition level. And perhaps the third group people will be people like us, the patient ambassador, which we consider ourselves has gone through the journey. We can tell you where are the important things, what are the important things you must do, where will be the so-called the danger that coming out, and then we will just help you to walk through the journey together with the doctor and your spouses. So last but not least, I wish to close with one golden statement, is that you must face it, do not run away from the problem. So early detection, early treatment, you will get early recovery. Thank you.
Thanks, Clarence. Thank you very much. I think, early detection, early treatment, early recovery, more often than not, and I'm sure the doctor would agree, is that nothing pains you more is that something that is treatable but was detected too late and then is untreatable and you lost a life over that. So, what Clarence has said, don't run away from it. And also developing a relationship with your doctor. Now, for most women, we actually have a relationship with a gynecologist. And so we see our gynae, on a regular basis, And I'm sure our two urologists would let us know is that it's common for men to have a relationship with their urologist. And there's really nothing wrong about it. And of course, maybe sometimes it's with other doctors. And we will come back to you, Clarence, later about, your journey. Next on my right hand is Dr. Lincoln Tan. And Dr. Lincoln Tan is an old friend. Almost every year we see each other because of prostate. And so today, we'll come to this time of the year again and to talk about, what are the preventions, etc. And, how common is prostate cancer these days, Dr. Tan? And do we see a trend that is getting younger?
Okay, so prostate cancer is the third most common cancer of Singaporean men. So about 700 men will be afflicted with it in a year. And if you look at this slide, on the left side is the 1970s and on the right side is 2017. You can see that the incidence of prostate cancer is rising quite a fair bit in Singapore. As to the age distribution, the risk group for men with prostate cancer starts from 50 onwards. Rarely you may get it a little bit younger than that. And of course, it gets more and more common as someone gets older. But as the incidence has risen, the proportion of men who are still considered young, that means in their early 50s to their early 60s, the proportion of men with prostate cancer in this age group has also risen.
So how old was the youngest patient you have for prostate cancer?
My youngest patient is about 48.
Oh, okay. So it has a certain trend. And it could be also because of now we have a lot of technology to detect it and then you can find out more.
Yeah, certainly I think part of the reason why we have finding more prostate cancer is also because men are being a bit more proactive in taking care of themselves. They go for health screening just like Clarence, or they don't ignore early symptoms and they go and seek help early, and then we diagnose more of these cancers.
So who is at risk of prostate cancer and what are the risk factors?
Okay. So the risk factors for prostate cancer, we can divide them into what we call non-modifiable or modifiable. So non-modifiable risk factors are things that you're born with. You can't change that. Okay, so number one is of course age. It is a condition that becomes more common as we age. Again, like I say, from the 50s onwards, you start getting a higher and higher risk. In terms of race, we do know that Caucasians and African Americans have the highest rates of prostate cancer in the world. So places like the US, UK, Australia have very high rates of prostate cancer. And so in these countries, prostate cancer is number one. Locally, Chinese seem to have a slightly higher risk than the Malays and the Indians. And of course, the third risk is family history. So family history, if you have a first degree relative, meaning let's say your father had prostate cancer, then you have about two times the risk of an individual who did not have a family history. But if the more relatives you have with prostate cancer, then the higher your relative risk. Meaning if you had 2 relatives, then you can go up to 3 times. If you have 3 relatives, it may be almost 5 to 8 times higher risk of prostate cancer. Then we go on to the modifiable risk. So one of them is diet. So we know that the Japanese men have the lowest rate of prostate cancer in the world. But Japanese men who migrate to America were found, the first generation were found to have higher risk of prostate cancer. But maybe that's because they moved to a new health system. But the second generation of Japanese men, that means these are Japanese ethnicity, but born and bred in America, eating the American diet and environment, their prostate cancer risk is almost the same as a Caucasian man born in the USA. So this is the evidence we have that diet and environment does play a part in the development of prostate cancer. We also know that obese men have a higher risk of prostate cancer, and not just prostate cancer, but of the fatal type of prostate cancer, the high-risk type of prostate cancer. And lastly, we know that men who smoke have a higher risk of prostate cancer. So
Just quick question is this: what if the mother of the man who has the mutated gene of the BRCA,
Okay, so the BRCA gene is a risk factor also for prostate cancer. You're right.
So if the mother has that, and then for a man, so he actually holds the risk factor.
He does. He may have the risk factor. You're right. So if you have been found, if your family member has a BRCA gene, then the man should also be more aware about it.
I see. Okay. And what else can be done to prevent or reduce the risk of contracting prostate cancer?
Okay. So when I talk about reducing your risk of prostate cancer, it means you're going to do some lifestyle changes to improve your risk or to reduce
lifestyle.
Yes, the lifestyle changes to reduce your risk of prostate cancer. But it's important to note that actually the number one cause of death in Singapore men is actually heart attacks or strokes, right? So heart disease. So whatever you do to improve your life should actually take care of both, not just the prostate but also the heart. So I always say heart healthy equals prostate healthy. All right. So first step, like I said, is to try to avoid obesity to maintain a healthy weight. Being obese does increase your risk of high cholesterol, high blood pressure, diabetes, and of course with that comes the risk of heart attacks and strokes. But again, as I said earlier, it does increase your risk of the high risk type of prostate cancer. And how can we avoid obesity? One way, of course, is through a healthy diet, low-fat diet with more fruits and vegetables. There is some evidence to show that lycopene-rich food, so lycopene can be found in things like tomatoes, is the red coloring in tomatoes. So food that are rich in lycopene may help reduce the risk of prostate cancer. Locally, we have fruits like guavas, watermelons, and papayas that are also very rich in lycopene, so you don't necessarily have to eat tomatoes all the time. Earlier, I mentioned about Japanese men, so their diet is rich in green tea, soya beans, and omega-3 fatty acids found in your fatty fish, such as your salmon and your tuna, and even the sardines. So these are also helpful. And other things that are rich in omega-3 fatty acids, especially if you're not the type who likes fish, is a flaxseed, which has also been shown to be helpful for reducing heart disease. And I would also recommend a multivitamin, a simple multivitamin, because often in our modern diet we may lack many micronutrients, and the multivitamin helps to make up for all of that. Now it's important to note that this is all part of a balanced diet. I'm not saying you eat only these things. Notice I didn't write anything about meat, and I didn't say you can't eat meat. I just said everything in balance, that maybe adding a little bit more of this in your diet will be helpful. And then we move on to the more difficult one, exercise. All right, so not only your diet, exercise has been shown to be important. It's important to avoid inactivity. That means something is better than nothing. So here I put certain goals, but we can slowly work your way towards it. So for aerobic exercise, the WHO recommendations are 150 minutes of moderate or 75 minutes of vigorous intensity exercise. And the best is just to space it out. 10 minutes a session, spread out throughout the week, makes it easier for you to make it a lifestyle change. The second thing is, a lot of people like to run and cycle. That's good, but you must not ignore what we call resistance training. All right, resistance training helps you build muscles. Not necessarily has to be weights training. Not everybody has access to a gym. Actually, one of the easy ways is actually using resistance bands, those rubber bands with varying resistance. And here in this picture, you can actually see our worn-out warriors with their regular resistance band exercise programs. And just to illustrate the importance of exercise, there was a study that showed that even in men who already had advanced prostate cancer, and they divided these men into one group who had supervised resistance exercise training and the other group didn't, and the group that had resistance exercise training actually lived longer, meaning that the benefit of this exercise was almost equivalent to giving them a new drug for their cancer. Okay. All right, so you can imagine that in someone who already has cancer, it has such a powerful effect that what it can do to someone who hasn't had cancer yet.
That's interesting. That's very, very interesting. Of course, we're not asking, aerobics exercise, from the Richard Simmons to the Zumba. There's so many choices these days that they could do, some of these cardio exercises.
Exactly. There's something for everybody.
There's something for everybody.
If you don't like to run, there's something else for you to do.
Yeah, even in the neighborhood, they have a lot of resistance training with all this equipment that they put around the vicinity. And I think it's very, very encouraging when you said that even with a little bit of resistance training, it actually proves to give them so much benefits, where people even with prostate cancer could benefit from that.
Yes, exactly.
Yes. And I'm curious, what are the symptoms? Because just now I remember Clarence mentioned that there isn't any symptoms from him. But what are the symptoms, that you find from people that has prostate cancer?
Okay. So back to this diagram. So this diagram is actually showing the different zones of the prostate. So the red thing on top is the bladder, and it's a red tube that goes in the middle of the prostate. That's our urethra where the urination goes through. So that green zone is where the benign growths of the prostate, what we call the BPH grows. And as you can see, it's surrounding the red tube. So when it grows, it squeezes that red tube and it causes urinary symptoms. All right? And these are the common urinary symptoms are like slow to start urination, slow flow, straining, and then because of that it causes bladder irritation, so it may lead to needing to go to the toilet more often, being urgent to pass urine, and of course the most bothersome is to wake up at night to pass urine. Okay, now prostate cancer on the other hand, more common are in that purple zone. So you can see that purple zone is a bit further away from that red tube. So in the early stages, when you have a small tumor there, it actually doesn't cause any urine symptoms. It needs to grow to a significant size before I can start pressing on that red tube and cause a prostate cancer. So in early cases, it can be just like Clarence. He had no symptoms. He was only detected when he had a PSA done. But because the group of men who have BPH, who have that benign growth, it's also something that starts from the 50s onwards. And so you may have urinary symptoms, and because you went to see a doctor for that, we may find the prostate cancer that was lurking in the same place at the same time. So often we say that although yes, early prostate cancer may not cause symptoms, but you should not ignore your urinary symptoms because you may have prostate cancer that we may find during the evaluation for these urinary symptoms.
So let me ask a question now, is that so, men who grow old and sometimes they have this issue, like you mentioned earlier, going to the toilet more frequent, have the urge to pass urine, having difficulty to pass urine. This is not a definite sign of old age, isn't it? It's actually, there is something going on with the bladder or the prostate that they should actually seek treatment and not assume that because I'm old, like a wrinkle or a grey hair that I have, I'm just going to sum it up that because I'm getting old, so I should just ignore the symptoms.
Exactly. So it's a disease that's more common as you get older, but it's something that is treatable, and so it's not something that you should ignore. I think treating it will bring a lot of relief to your quality of life, and there are a lot of medications and things that we can do to help with the symptoms and the underlying problem. But also in this case, we may detect something else that's wrong.
So somebody in their 70s with a healthy prostate, for example, healthy bladder means that they may not have those all issues that everybody thought it was come with of being old age because they have a healthy prostate. Yes,
that's true. Not everyone is destined to have urinary symptoms as you get older. There are many men who actually do not have problems.
Yes. So that's a key word here. It's not necessary, but it can be treated. And I think, like we mentioned again earlier, early detection, early treatment, and anything can be treated. And it's very restricting to your lifestyle. If you always feel the urge, but then you're not passing, then you're afraid to travel, you're afraid to leave the house, and then you started to live a more sedentary lifestyle. And then we're not getting the exercise, and the lifestyle is different, and the heart is affected, and everything else is affected. So it's really a cycle, isn't it?
Yeah. And maybe I take this opportunity to talk about the other symptoms of prostate cancer that we want to discuss. So earlier we talked about early symptoms. Now there's some more alarming symptoms that definitely should not be ignored. Okay. So unfortunately, amongst the men that diagnosed with prostate cancer in Singapore, almost 1/4 of them actually discovered stage 4 cancer. That means these are cancers that have already escaped from the prostate, they have gone outside of the prostate, which means they are essentially incurable disease. All right, so this is late stage disease, and in comparison to, like, say, other first world countries like America, where only 4% are diagnosed in stage 4, it just shows that we do have some ways to go to helping men with prostate cancer in Singapore. So some of the symptoms that definitely should not be ignored are blood in the urine or the semen. All right, so if you ever see your semen is brownish in color, that is definitely not normal because semen is produced from your prostate. So any blood from there, you have to be worried about something in the prostate. This is one that's sometimes ignored, is persistent back pain or pelvic pain or hip pain, bone pain essentially. So on this diagram, you see this the skeleton there. All those black dots are actually prostate cancer that spread to the bone. So prostate cancer, the first thing that it wants to spread to outside of the prostate is actually to the bones. All right. So some men will think, oh, this back pain is part of growing old, or maybe I exercise too much. Right? But I think any pain that lasts for quite a long time, you should at least see a doctor to check out what. Don't assume that it's just part of growing old or anything like that. Sometimes it can be the first sign of advanced cancer. And other non-specific symptoms such as feeling very tired that you cannot explain, or loss of appetite, or loss of weight that is prolonged, these are all symptoms that may be some advanced disease going on, and definitely should seek some advice. And then lastly is about issues with erection. So the nerves that control erection actually wrap around the prostate, and sometimes some advanced cancers may actually invade those nerves and cause problems with erections. Now, most of the time, erection problems are not due to prostate cancer. However, if you do have a problem with erection, it's useful to see a doctor to at least make sure that it's not caused by prostate cancer.
You mentioned just now is that because the nerves is wrapped around the prostate. So if they have a prostate operation, it doesn't mean that it will naturally lose the ability to have an erection.
So depending on the cancer, right now with our advance in technology, we're able to actually spare the nerves, that means peel away the nerves from the prostate when we remove it, and spare the nerves so that men will still be able to have an erection after the surgery. Of course, this depends on the stage of the disease and many individual factors.
So again, early detection, early cure,
yes.
And then we will have less damage to the body.
Absolutely.
Cool. Okay, that's great. And so how do we, this is part of it, that we detect the cancer early stage, isn't it?
So how can we detect cancer early? So again, like I say, one, if you do have any symptoms, please see your doctor early. Two, I think is, as Clarence has shown, right? If you're interested to have the early detection, then you need to have a conversation with your doctor about getting a prostate checkup or a PSA test done, and discuss the pros and cons of having it done, and then decide if it's for you, then go ahead and get tested.
Yeah, like you mentioned earlier, it was like 48 years old is the youngest that you have in terms of patient for yourself in your personal experience. And then we know a lot of executives have yearly body checks, and PSA is just one of the checks that they could do, and it's just by drawing blood. In fact, a lot of times when we do our full body checkup, the blood is already drawn. Then might just include that and have it tested, and have the whole thing to be monitored. Clarence monitored from 2013 to 2015. It was a spread of time that he realized there was an increase. And you do need a period of time to see and monitor the trend too. And this is part of early detection.
Yes.
I see. That's interesting. So, do you have anything else to add in terms of your slides?
No.
No. Okay. Thank you, Dr. Lim. Thank you very much. So, Dr. Lim, diagnosis, treatment of prostate cancer. So how is prostate cancer diagnosed?
Okay, so in general, prostate cancer is usually diagnosed, like Clarence has alluded, it almost always starts with a PSA testing.
Okay.
Yeah. Then once the patient has a PSA that is abnormal, he will be referred to see a urologist, where in the clinics we will do physical examinations, which include what we call a digital rectal examination. Mm-hmm. Okay, there are other adjuncts which we can use nowadays to help with diagnosis of prostate cancer, for example, MRI of the prostate. So what exactly is a PSA? So PSA is called the prostate specific antigen. It is a glycoprotein that is produced by the cells in the prostate. So when the prostate is healthy, the architecture of the or the way the cells are arranged is that it does not allow a lot of PSA to be leaked out into the bloodstream, which is why when you do a blood test, the PSA may be within the normal range. But when there is a disease process, which can be infection, inflammation, or even cancer, this organization is lost, and this leads to an increase in the amount of PSA that's being leaked out. So, like what Clarence has said previously, generally we take a cutoff value of 4 and below as a normal PSA. But bear in mind that a normal PSA does not mean that you do not have prostate cancer. It just means that your risk of having prostate cancer is lower. Okay, in general, if a patient has a PSA of between 4 to 10, he has about a 25% risk of having prostate cancer. So PSA being non-specific, and when the patient comes to see a urologist, one of the most common yet unpleasant physical examination which we do is we will insert our fingers into the rectum to have a feel of the patient's prostate. Okay, this process is actually not painful, although it can be a little bit uncomfortable. What we are feeling for is any signs of prostate cancer which can present as a hard nodule. So if a patient has an abnormal PSA as well as an abnormal physical examination in terms of a digital rectal examination, his risk of prostate cancer can go above 50%. In the recent years, there's also an increased use of MRI of the prostate to help us diagnose prostate cancer. It has been shown in many recent papers that MRI of the prostate actually will help detect clinically significant prostate cancer while reducing the overdiagnosis of indolent cancers. So how do we define clinically significant prostate cancers? To put it simply, clinically significant prostate cancer refers to cancers which, if you do not treat, they can cause death in the near future. As opposed to indolent cancers are cancers that even if you do not treat, they are unlikely to result in death of the patient. Okay, so after MRI is done, the radiologist will usually look at the images and may mark out certain areas which may appear to be of interest. And generally, they will give a score of between 1 to 5. If they mark a score of 1 or 2, it means that this area of interest, it is most likely to be non-cancerous, as opposed to a score of 4 or 5, where there is an increase or higher risk of that area being cancerous. And so that can help the urologist decide when to do the biopsy. Okay, so the biopsy is the only way for us to confirm the presence or absence of prostate cancer. So there are two approaches where we can go about getting tissue from the prostate. The traditional approach will be via the transrectal route, where ultrasound and the needle is inserted into the patient's rectum, and the needle is inserted from behind into the prostate to take some tissue. So the main limitation of this approach is if the cancer is found in the front part of the prostate, that may not be so easily detected. Yes. So there are a second approach which has gained popularity in recent times is what we call a transperineal approach. So the perineum is this part of the body that is between the scrotum and the anus. So the urologist will insert a needle which is guided by the ultrasound through the rectum into the prostate to take tissue to test. So in general, the risk of a prostate biopsy will involve bleeding, especially when you pass urine. It usually lasts for the first few days, but it's generally self-limiting and it goes away by itself. There's a small risk of infection, with the transrectal approach having a slightly higher risk. And there is also a small risk of retention of urine, which means that the patient may temporarily be unable to pass urine immediately after the procedure. Generally, the treatment is to leave the patient with a urinary catheter or a urine tube to drain out the urine for 2 to 3 days, and after that the urination will go back to normal.
So that's because the procedure has caused some swollen to the prostate.
Yes, it's a bit like when you sprain your ankle gets swollen. So it's the same thing when you biopsy the prostate. There can be inflammation and swelling that can compress on the red region with which Dr. Tan has previously alluded to. That can result in a temporary inability to pass urine.
So when it's reduced, then the catheter can come off,
yes,
and then
correct.
it'll be normal again.
Yes.
So it's temporary.
Yes, temporary.
Okay.
Usually lasts for a few days.
Okay.
Okay, so before we go into treatment, we need to stage the prostate cancer. So generally, prostate cancer can be roughly divided into 3 stages. The first stage, or the better stage, will be what we call a localized prostate cancer, where the prostate cancer has not gone beyond the prostate. So it's still confined within the prostate. The second end stage will be what we call a locally advanced prostate cancer. This is when the cancer has gone beyond the capsule of the prostate and into the surrounding tissue, for example, the bladder or the rectum or the fat around the prostate. Okay. in more advanced cases, sometimes the cancer may have spread to the regional lymph node in the pelvis. So the lymph nodes are sort of like a policeman or immune policeman in our body, where it drains fluid around the organs. So what happens is the cancer may follow the blood or the fluid to the lymph node, and they get deposited there before they launch to other place often. And the next stage will be what we call a metastatic prostate cancer. This means that the cancer has spread beyond the pelvic region into the other parts of the body. Prostate cancer seems to prefer the bone. So bone is one of the most common sites where prostate cancer will spread to. Okay, the other organs like lungs and liver can also be affected. So traditionally, we often use what we call the bone scan to diagnose metastatic prostate cancer. In the recent years, there are more sensitive tests such as the PSMA scan that will allow us to pick up a smaller focus of cancer that has gone beyond the prostate. Yes.
Have you ever have cancer patients was detected with prostate cancer because they went through a bone scan?
Generally no, because unless the patient has a fracture and when the doctor examined him, for example, using the digital rectal examination, and it found a hard and nodular prostate that's very suggestive of prostate cancer, then they may proceed to do a bone scan. But again, a bone scan is not specific for prostate cancer. In general, when we want to diagnose a cancer, we want to catch the cancer itself. So it will almost always require a histological or tissue confirmation that is usually taken from the prostate itself.
Would patients have choose not to have the biopsy, but instead do MRI immediately, do everything else except having, the sort of biopsy? Okay,
so whatever adjuncts like MRI or PSA or physical examination, these are not specific to prostate cancer, although they are what we call situational or circumstantial evidence to point towards prostate cancer. Well, there are some patients who we treat the prostate cancer what we call empirically, okay, because they are at very, very high risk of a biopsy. Which means that the fact that you do a biopsy, it puts the patient's life in danger. These are the patients, not really diabetic, but sometimes patients with advanced heart problems and heart disease. And these kind of patients are the ones that sometimes they may not want to tissue biopsy. But generally, as urologists, we will still offer a biopsy because that gives us the gold standard.
I see. And how do you treat them when you found that someone has prostate cancer?
So treatment of prostate cancer, it is highly individualized. Okay, not all patients are the same, and also not all prostate cancer are the same. So there are various kind of treatment modalities that we have. This may include observation, which can be divided into active surveillance or watchful waiting, or curative modalities like surgery or radiotherapy. So the factors that actually affects the decision to what kind of treatment a patient undergoes depends on the patient's age, the patient's medical issue and his life expectancy, and also his individual preference and his expected quality of life after treatment. But also very important is the disease itself. Generally, we will classify prostate cancer into three main risk groups, being the low risk, intermediate risk, or high risk group. In general, patients, prostate cancer being classified into low risk ones tends to grow slower and progress slower, as opposed to those that are classified into the high risk. These are very aggressive prostate cancer, and they can move from stage 1 to stage 4 in a very short period of time. So these are the patients which we want to catch and treat them early. Okay, so before we understand the rationale of why we do certain treatment, we have to know the natural history of prostate cancer. Okay, so if you, this is a sort of like a table to show the natural history. Okay, if you look at the top right-hand corner, if we have a man that is at 75 years old and is diagnosed to have a low-risk prostate cancer, The dark black color area means death from prostate cancer, and the gray area means death from any other cause except prostate cancer. So as you can see, an older patient with a low risk prostate cancer, his chance of dying from prostate cancer is actually very low. But even if the prostate cancer is not treated for the next 10 to 15 years, but his chance of dying from any other cause approaches 80%. Okay. Conversely, if you look at the left lowermost table, you see a huge area of black. These are younger patients with aggressive cancer, and if we don't do anything about it, the chance of the patient dying from prostate cancer is very, very high. So, knowing the natural history of prostate cancer, now we can discuss why sometimes when a patient has prostate cancer, the urologist say, don't worry, we may not need to treat you, we'll just observe you. This is, so these patients will be put on what we call an active surveillance protocol. The main advantage of active surveillance is that we want to delay treatment so that we can pick out patients who will benefit from the treatment and yet not subject to the vast majority of patients with low-risk prostate cancer to the side effect of treatment. Okay, so of course there is a theoretical disadvantage in this approach, in the sense that patients may fear that by not doing anything, the prostate cancer can spread during the time where they are waiting, and this can lead to a missed opportunity of cure. But in general, as long as the patient is compliant with the clinic visit, this should not happen in the vast majority of cases. Of course, active surveillance is not suitable for highly anxious patients who cannot live with the fact that they know that they have a cancer and not treat it. Because if they have to keep thinking about having a cancer and it affects their daily activity, I think they are better off being treated. Okay, of course, on the other extreme of not doing anything is what we call watchful waiting, which is sometimes confused with active surveillance. The main aim of watchful waiting is actually to not to cure the cancer, but to actually palliate, or what we call relieve, whatever symptoms the prostate cancer will eventually lead to. Okay, so these are usually reserved for older patients with multiple medical problems with a limited life expectancy. Okay, so of course, as doctors, and we want to cure our patients as much as possible. So in general, for prostate cancer, there are two modalities which we can cure our patients. One will involve surgery. This will be what Clarence has underwent, what we call a radical prostatectomy, where the whole prostate gland is removed, as well as these two small glands that lies directly behind the prostate, called the seminal vesicle, which serves to store the semen. So once the prostate as well as the seminal vesicles are removed, there will be a gap or interruption between the normal urinary tract. So what the urologist or the surgeon will do is we will stitch whatever the remnant of the urine tube back to the bladder, so that the patient still pass urine via the normal way. Okay. In this day and age, there are basically three approaches where we can do this kind of surgery. Okay. Traditionally, this is done with an open approach, where there is a midline scar from the umbilicus all the way down to the, or rather the belly button all the way down to the pubic bone. But more recently, more and more institutions are adopting the minimally invasive form of surgery, or what we call a keyhole surgery, which can be either laparoscopic or robot-assisted. The main benefit of a keyhole surgery is it has less pain, it leads to less blood loss during surgery, and faster recovery and shorter hospitalization. Okay, so there are various advantages with surgery. The main advantage is that once we remove the prostate gland, especially in the localized prostate cancer, the chance of cure is very, very high. Okay, of course, the disadvantage of doing a surgery is it is invasive, and there are certain risks associated with surgery as well as general anesthesia. The next form of treatment will be RT, or what we call radiation therapy. Okay, so in general, this radiation can be given from outside or within the prostate. So the first way is what we call a EBRT or external beam radiotherapy. This is where the radioactive wave is given from the outside of the patient. Okay, in general, each course of treatment will consist of anything between 20 to 30 over sessions, where the patients will have to go to the radiation oncologist every day, 5 times a week, where they undergo this radiation treatment. The main advantage of radiation is it can be done in patients even with multiple medical problems where the risk of surgery is very, very high, and we can still cure them of the prostate cancer. Okay, of course there can be some disadvantage similar to surgery. They can lead to erectile dysfunction as well as urinary incontinence, and sometimes the bladder as well as the rectum can have some radiation injury, and in the near future or in distant future they may result in bleeding from these areas.
This one is with the cast. They have to build a cast for them to pinpoint or to...
Okay, so now the patient undergoes a CT scan where the prostate will be delineated, so that the radiation can be then directed onto the prostate and less on the surrounding tissue. Yes. Okay, the next form of radiation will be given from within the prostate. This consists of source that is being introduced into the prostate and can be either low dose or high dose. The main advantage of this form of radiation is that it minimizes the radiation injury to the neighboring organs of the bladder and the rectum. But this form of radiation is not suitable for all patients because if the patient has a very, very large prostate or more aggressive form of cancer or have previous prostate surgery before, then they are not really suitable for this form of radiation, or what we call brachytherapy.
Why?
Because the anatomy of the prostate will be altered by surgery, okay. and if the prostate is very, very big, there may be under treatment of areas of prostate.
So this is selective?
Yes, correct. Okay, the next big group will be what we call locally advanced prostate cancer. These are generally highly aggressive prostate cancer. Okay, so usually the doctors will give all that we have got to try and cure the patient. The main keyword for this kind of treatment will be what we call multimodality treatment, where patients may undergo surgery, radiation, or even hormonal therapy. Okay, so the third stage or what I call the metastatic stage of prostate cancer mainly will be what we call androgen derivative therapy, or what more commonly known as hormonal therapy. Okay, so to put it in layman terms, it can be, the prostate cancer can be thought of as feeding on the male hormones, namely testosterone, to grow and progress. Okay, so what the mainstay of this treatment is, it serves to cut down or reduce the level of testosterone in the patient, so that in a way it starves the prostate cancer cells and slows down or delay its growth and progression. So there are two main ways where we can achieve this. One is by surgery, where both of the patient's testes will be taken off, or can be via drugs, most often in the form of injections every 3 to 6 monthly.
The injection is actually reversible, isn't it? They stop the injection.
Yes, so each injection, depending on what kind of drug you use, usually lasts for, it can be whether 1 month, 3 months, or 6 months. So the effect will wear off after the medication effects goes off.
Okay.
Yeah. Okay, and it has been shown in the last 10-20 years that chemotherapy actually, in combination with androgen derivative therapy or hormonal therapy, actually significantly improves both the progression as well as the survival of a patient. Like a lot of us will know, chemotherapy is actually associated with some side effect, as shown in the blue table on the right. Yes.
Interesting. There's so many types of treatment. Mm-hmm. But we don't do a one-size-fits-all kind of treatment, do we?
No, we do not, because every patient is different, every cancer is different. We aim to tailor our treatment according to the patient's needs as well as the patient's disease.
So, have there been any advances of prostate cancer treatment since?
Yeah, I think the last 5 to 10 years has been very exciting times in the treatment of prostate cancer. So, in fact, in every treatment modalities, there have been advances. For example, in surgery, there are newer surgical techniques that can help to improve or preserve the patient's continence or erectile function in selected patients. Okay, there's also more doctors adopting what we call an enhanced recovery after surgery protocol. This will lead to faster recovery of a patient after surgery and decreasing the length of stay of the hospital, of the patient being in the hospital. In fact, in some centers, in highly selected motivated patient, this procedure can be done as a day surgery. Okay, in the realms of radiotherapy, we have what we call SBRT or stereotactic body radiotherapy. This can be easily explained as a highly precise form of radiotherapy where the radiation can be delivered at higher dose, more specifically and more precisely on the prostate and less on the surrounding tissue like the bladder as well as the rectum. This should cut down on the unnecessary side effect associated with radiotherapy. But the most advances have been in the drugs that we can see over the last 5 to 10 years. Can we go back to the previous slide? Okay, so prostate cancer was first diagnosed in 1980s. Okay, and over the next 100 years, it takes us about 100 years for us to actually find out that prostate cancer is hormone dependent, which means that we can manipulate the hormones to treat the prostate cancer. However, even when we know of that fact, there was no effective treatment. It took us another 50 years before the first medication where we can do something about the hormones appear. So that will be in the 1980s. But since the 1980s and the 2000s, there are many drugs that have come into play, especially in the last 5 years. This will involves chemotherapy drugs, various hormonal therapy, pathway blockers, and immunotherapy drugs. So this has greatly increased the options that we have that we can use to treat patients with prostate cancer. And when the patient now fails a certain drug, we can go on to the second line, third line, fourth line, and so forth. So I think, and as we speak more and more, all of these agents are being discovered, and the sequencings are being protocolized. So I think the treatment for prostate cancer in the near future will be very exciting.
I noticed that in my years, I started volunteering for Singapore Cancer Society since 2008. And over the years, I realized is that there are so many treatments for different types of cancer getting more advanced that at any stage, even at any stage, the patient could actually live comfortably with good quality of life with treatment to keep them feel comfortable. And we never know what's coming up next, with treatment, that something might come as a cure or something might help them to, live their life with good quality for a period of time. And for some patients where they were waiting for the children to grow up to that graduation, to that wedding, the 3, 4, 5, 6, 10 years is very precious. And this is the miracle of medicine, and there's a big group of people behind the scene working relentlessly for all these advances and all this medicine, where all we need to do is to look after ourselves and go for a health check to get a diagnosis and be treated. So I think it's a good bargain in some ways. So everyone should look after, and again I encourage every man. I'm not sure if Dr. Tan agree that. Do you think every man should have a urologist like we women have a gynae?
I think every man should have a regular doctor taking care of them. It would be good to have a urologist, but it's not. I think even a GP, or not say even, everybody should have a regular doctor taking care of them.
Yeah. One other thing is that, of course, when you go to polyclinic for some reasons, then you may not have. But if you have a non-GP, for example, I have a GP who's seen me for like the last 20 years, and I'm happy, and she knows exactly what are the medication that I need, to relieve something, So that's medical history for us, right? Thank you both doctors. Thank you very much, Clarence. And we have come to a stage where we are now ready for questions, and there are a lot of questions. So we wanted to see how we could answer this question. For example, so the doctor has actually sent me for a PHI test instead of a PSA test. So my GP called for a PHI test instead of a PSA test. Is that correct?
Okay, so that's a good question. So the PHI test is actually called a Prostate Health Index. Okay, so it's actually the PSA test actually is not very specific for prostate cancer. So in the most common number, which is between 4 to 10, actually only 25% of men will be found with prostate cancer. We say it's abnormal, but only 25% have cancer, which also means that 75% of them will have gone for a so-called unnecessary biopsy, right? We biopsied and we didn't find cancer. So the PHI is a test that improves on that. It's actually a more cancer-specific subtype of the PSA, and it's been shown to be 3 times more accurate than the PSA. And so in a select group of men where they have what we call the equivocal range of PSA, that means they have an abnormal PSA between 4 to 10, but we want to further stratify them so that we can find, hey, are there some of these men that maybe don't need to be biopsied? All right, so this PHI test helps us with that. And the good thing about this test is it's actually been validated in our local population. There was a study done in NUH and Tan Tock Seng where we actually gathered 150 local men, and we tested this PHI on them, and we were able to save half of these men from going for an unnecessary biopsy. And these results have been actually replicated in other predominantly Chinese populations in Hong Kong, Taiwan, China, and with the same results. So actually this test has been validated in our local population.
So if you're asking me if this is correct, I think what your GP is trying to help you is to see if with this PHI test you could actually not have to go for the biopsy.
Yes, I think it's for just to improve the risk stratification as compared to the PSA alone.
Yeah, to study it higher and
Yes.
more clearly. Okay, this is a question is that what would be the PSI level for the cancer to spread to the bones or other part of the body?
So you're referring to PSA level?
PSA, yes. Sorry.
So generally, the higher the PSA level, the more likely that the cancer may have spread to other parts of the body. But in general, based on our experience, when we see patients with stage 4 or metastatic prostate cancer, their PSA is at least in the region of at least 50 to 100, sometimes up to 1,000. Yeah, but this is not a hard and fast rule. Yeah. There are certain cancers that are very aggressive and yet don't give out a lot of PSA, but that is the minority. Yeah, but of course we have seen patients with lower PSA, like between 20 to 30s, and the cancer have gone to the bones. So I think we shouldn't just look at the PSA alone and say that whether the patient has cancer that spread to the bone, but rather we should do further tests and imaging to confirm or exclude that.
Well said, doctor. I think this is not about the numbers, but more so to have more investigation and have a peace of mind.
Yes.
I think having a peace of mind, and if you need to be tracked, sometimes the readings, everything else is inconclusive. The doctor may, like you said, continue to watchful and see what happened to the patient over a period of time. Now, this is a hereditary question, and he asks is that the father has prostate cancer, died because of it, and 3 of the elder brothers has a very high PSA reading, and they have to do regular PSA test. He's now 43 next year. Does he need to go for PSA test?
I would say right now only one relative has been diagnosed, but typically what we call the hereditary prostate cancer is actually very uncommon. Maybe less than 10% of cancers are hereditary. But to be on the safe side, we typically say, okay, 10 years before that family member was affected, you should start. If that's earlier than 50, or otherwise 50 years old. So if let's say the father got it at 55, he should start by 45. Yeah.
And how often should they check their PSA? Yearly?
So in generally we say yearly, but it depends. If you have your first PSA was very low, like say like Clarence was like near 0, then you could probably defer it for 2 years or 3 years. But once it starts coming up, so let's say at 3, I would repeat one the following in 1 year interval. But it doesn't need to be done like every 3 months or 6 months. I think at most is 1 year apart if it's normal, but potentially longer interval if it's very, very low.
I see. Okay. How do we differentiate UTI and prostate cancer? Urinary tract infection, I guess.
Okay, so urinary tract infection, generally patients should have symptoms, okay, of the lower urinary tract. So they may have what we call dysuria or burning sensation or painful when they pass urine, or they may need to go to toilet more often, okay, or if the infection is severe, they may even come down with a fever or blood in their urine. Again, prostate cancer, especially the early prostate cancer, they are asymptomatic, okay, which means that most of the time, even if the patient have prostate cancer in their prostate gland, they do not have symptoms. But any of the above symptoms that I have just mentioned that can happen in UTI can also happen in prostate cancer. Yes, so actually for men, it is not common to have urinary tract infection. So if a man will have a urinary tract infection, it is advisable for him to seek a medical consultation, so to rule out any underlying problems. And prostate cancer may be one of it.
I see. Okay, so there's a couple of very interesting questions here. One is, does a patient which is having first stage of prostate cancer, and if they do a biopsy, would it increase the spread or cause it to spread?
No, absolutely not.
Yeah.
This is a common myth. People worry that by putting a needle in that we spread the prostate cancer, but there is no basis of truth to that. So don't worry, that is the way we diagnose, and there's no risk of spreading cancer.
Okay. The other one is, if a doctor did a digital rectal examination and said that the prostate is slightly hard, should that be a concern? And for someone who had a radical prostatectomy and now have biochemical recurrence and then radiotherapy, is this something to be alarmed?
Okay, so I think I'll take the first question first.
Okay.
Abnormal digital rectal examination. So, digital rectal examination is a physical examination. In general, the prostate, if there's cancer, it should feel a little bit harder than usual. But it is also based on the doctor's experience. Generally, urologists are trained in to do I would think, hopefully a better digital rectal examination, okay, because we do it more often. Okay, but again, in our hands, this is not 100% accurate. So in general, we will still complement the digital rectal examination with a PSA test. Of course, it comes to a stage where we have to decide which is more important. For example, if let's say a urologist thinks that the digital rectal examination is truly very suspicious of prostate cancer and yet the PSA is low, we may then engage another modality, for example, MRI or even a PHI test, okay, to further re-stratify this patient. To see whether or not we need a biopsy. But if all else fail, we may recommend a biopsy for this patient just to be sure that it is indeed not prostate cancer. Okay, as regards to your second question about biochemical recurrence after radical prostatectomy.
Yes.
Okay, so generally biochemical recurrence after radical prostatectomy, if we take it as prostate cancer as a whole group, it is not common. Okay. However, if the patient belongs to a high-risk prostate cancer group or is a locally advanced prostate cancer, then radiotherapy may be part of the treatment. Okay, especially when there is biochemical recurrence. For example, if a patient has high-risk prostate cancer and the patient undergo a radical prostatectomy, taken in general, there is at least a 30 to 40% chance that he may require what we call salvage radiotherapy in the years to come, should the biochemical recurrence occur. Okay, then of course there's a question if it's a high risk, why don't we give radiotherapy for all patients? Okay, but if you're talking about 30 to 40% of patients eventually requiring radiotherapy, if we look at the other side of the coin, there is slightly, at least half of the patient may not require radiotherapy. So this is when frequent monitoring and communication with urologists will come in. In general, having radiotherapy after prostatectomy should not be considered a treatment failure, but is part of another modality of treatment to consolidate the treatment, so to effectively cure the patient of their prostate cancer.
I see. I have a question, Clarence, for you. You mentioned earlier that right after your prostate cancer, you have incontinence and up to 4 diapers a day.
Yes.
9 months later, you were traveling to Shangri-La. How long did the symptom relieved? What happened through the course from 4 diapers to being able to travel? How did you work with your doctors?
Okay, I would say that 2 parts, because it depends on the individual's body structure and system. After 6 months, straight away it's just like cliff drop, boom, no need to put diaper. Yeah. Then some of my friends were swimmer and physically very strong. In fact, after 1 month, pop, straight away no need to put diaper. So it very depends on individual. Of course, some do the casual exercise, but honestly, I say that I never do any. So it all depends individual.
So you are also a patient ambassador, a walnut warrior. So in the course of you helping other patients as a patient ambassador, is incontinence a factor that disturbs them very much? And do you have a lot of cases where it's extended?
I should say majority are not affected so much of the incontinence. Most of them, after they finish, after 1 month, 2 months, they go swimming. For me, I take a more cautious approach. After 6 months, for them, some they just feel bored at home. So after 1, 2 months, they just go swimming, and it helps. Swimming helps. So
Swimming
I don't
helps.
know. Yeah.
Okay. So we have a question here: is that after 2 years of prostate cancer operation, the person is still experiencing incontinence. So as a doctor, what would be your advice?
So if a man after 2 years after prostatectomy is still having incontinence, then it's unlikely that they will recover naturally. All right. So it really depends. If it's very mild, they may choose to just put up with it and just wear a pad. But if it's more bothersome, then there are surgical procedures we can do to fix the leak.
Okay. So usually, like what Clarence and all his buddies has happened is that within a 6 months period, it will naturally heal.
So typically, we will quote about maybe 60 to 70% will recover within 3 to 6 months, and at 1 year, usually 90 to 95% will have recovered. So typically, if after 1 year you're still leaking, then generally that means you kind of plateau off, and you're probably not likely to recover any further.
This is an interesting one that says, when can nuclear medicine, PRRT, be considered?
I have not heard of that.
You've not heard of that? Okay, good. This is a question that we just received through one of the Zoom or Facebook. So perhaps either the person could send in the question before 9:15 with additional information. Otherwise, this question we are unable to fulfill in terms of that. Now, is there a sharp rise of prostate cancer recently in maybe the last 5 years?
So I can see that there is an increase. I wouldn't say sharp, but it is increasing incidence throughout the last 40 years.
Due to screening, better screening?
I think it's a combination. I think 1 is of course better detection. 2 also maybe because our diet and our environment has changed. And so there may be actual increase in the numbers of prostate cancer. So it's a combination of both.
And I'd like to add, I mean, nowadays men are more aware of prostate cancer, so that may lead to earlier detection and slightly increased incidence.
Okay. For age 75, do the advantage of doing a biopsy outweigh the risk or misdetection or die from other OH causes?
So again, it depends on the patient factor as well as the disease factor. So not all 75 years old are the same. I've seen some of my patients 80 years old and they're still running marathons, and there are patients who are 60 years old and already bedbound with multiple strokes or heart attack. So this is one area which we need to consider when we talk about weighing the risk versus benefit of a biopsy. So generally, the risk of a biopsy is low, but there is, we'll usually quote a more dangerous risk like severe infection in the region of 1-2%, but blood or lesser milder infection can be more prevalent, up to 10-20%. So all these have to weigh with the patient's risk of having prostate cancer. For example, if the PSA in this 75-year-old patient with a huge prostate of maybe 100 cc, and the PSA is only about 4.5 or 4.01 kind of thing, and the digital rectal examination is negative, or even if the MRI is done and it doesn't show any suspicious area, we may not recommend a biopsy. So it is not a piece of evidence here and there taken in isolation, but we have to combine
all the factors,
all the pieces of the jigsaw puzzle to form a full picture before we decide.
Okay, saving the best for the last, and this is the question that always comes in every year when we have prostate cancer forum, is this: does having more frequent sex actually reduce the risk of having prostate cancer?
So there was a study that showed that more frequent ejaculation, so men who ejaculated more frequently seem to have a lower incidence of prostate cancer. And they did a study up to 21 times. So based on quarter, if you did like 0 to 7, it was this much reduction, 7 to 14, this much. So the group went up to 21 ejaculations a month, and they had the lowest incidence of prostate cancer. Now, all we can conclude from this is that, because it could be different, it could be that men who ejaculate more often are healthier in a different way. But all we can say is that it's probably not harmful that more frequent ejaculation or more frequent sex will not lead to a higher risk of prostate cancer and may be beneficial.
Okay, Dr. Lim, you want to add anything on this
No,
topic?
I think we are all quoting on that single study that we see in the newspaper a few years ago.
But then again, do we have a lot of monks or Catholic priests that has high prevalence of prostate cancer?
Actually, no, because ejaculation is one thing. Okay, I mean, like what the Dr. Tan has said, the environment and the food that we take is also a big risk factor. So I would think that monks and priests, a lot of times they do not take food that is high in animal fat or Western diet, or rather food that consists of more vegetables and maybe lycopene, soy. So all this may have actually helped decrease their risk of prostate cancer. So I'm not sure. I don't have evidence to say that they are of a low risk of having prostate cancer, but I can definitely say that they are not at higher risk of having prostate cancer as opposed to the general population.
Okay. The PRRT is peptide radionuclide receptor therapy, which is being offered in the general hospital and some of the private hospital. Is this something that we use to treat prostate cancer?
I think it's referring to this lutetium. It's a targeted therapy for prostate cancer. So I think Dr. Lim mentioned the PMSA. So this is a tracer that attaches specifically to prostate cancer cells. So this is one of the latest therapies. It's usually kept to what we call very late stages of cancer, where all the other treatments have failed, and then so this is one of the potential treatments, what we call lutetium-directed radionuclide therapy.
Okay. So prostate cancer takes time to develop.
Yes.
From stage 1 to stage 2, stage 3, to something that, like you mentioned, to a very late stage where perhaps the majority of the cure is unable to fulfill. Okay. Now we have another one here, which will be the last question is. If there is any blood in the urine, any blood in the semen, is that a cause for alarm?
I think earlier I've already mentioned that any blood in the semen can be prostate cancer. Of course, it can be other things like infections, prostate stones, etc. Similarly, blood in the urine, besides prostate cancer, there are other causes, bladder cancer, kidney cancer, stone. So there are many reasons for these symptoms. I think the main message is that it should not be ignored because none of them are good.
Yes, yes. So when you see blood, see your doctor. And the best thing is to see your doctor almost immediately because there may be still samples that they could see and have it and examine and test it. So that's the thing. You shouldn't be feeling in pain, and if you're in pain, you should see your doctor. So coming to the end of the evening, I would just like to come back to Clarence, is that what would be a giveaway that you give to every man, you know, having someone that has prostate cancer, recovered from it, living a very active life, you know, what would be your advice to them?
Okay, as I said earlier, early detection, early treatment, early recovery. So everyone don't have to worry about your walking the journey, the cancer journey alone. There's always helps around. For instance, Singapore Cancer Society hotline, for instance, all the doctors here who are very good in helping patients. But one word of caution is never try and eat those tablets and whatever medicine outside which you can buy off the shelf, and then suddenly you find that my PSA from 10 dropped to 3 to 2 to 0. Those are just
camouflage.
Fake. Yeah, but your cancer cell can be still growing inside. So only trust your doctor. Doctor is the best.
Have a relationship with the doctor and trust the treatment.
Yeah.
Dr. Tan, any parting words?
So I would say that the horizon for prostate cancer is very bright. There are many new treatments to help men with prostate cancer at all stages. However, nothing can beat the disease biology if you are found too late. So no matter what, the best is still, if you are going to have prostate cancer, to have it detected early. So please don't ignore any symptoms and do consider having a chat with your regular doctor about early prostate cancer detection.
Dr. Lim?
Yes, like what Dr. Tan has said, if you have symptoms, see a doctor. Don't be like an ostrich and bury your head under the sand and think that it's not there. Because I think it is important to know that you have an issue, and even if you diagnose with prostate cancer, you may not necessarily need treatment, but it is better for us to re-stratify the cancer for you so that we can recommend the best option rather than to pretend that it's not there when it's actually there.
Or think that because you know you've been eating fried food and then it's very heaty, that's why it's all these symptoms, because it's not true. All right. Coming to the close, thank you doctors, thank you Clarence very much. And this virtual event is possible, organized by Singapore Cancer Society, supported by Changi General Hospital, Tan Tock Seng Hospital, Tan Urology, and sponsored by Icon Cancer Center, AstraZeneca, and Astellas. Thank you doctors, thank you Clarence.
Thank you,
good night.
Thank you.
Thank you.
Thank you.